Now, in terms of like management of mitochondrial diseases, we have seen that each system requires a different approach. But to improve the overall health for patients with mitochondrial diseases, the most important thing I probably think is diet and exercise. Currently, there is lack of clarity about what is an optimal diet in mitochondrial disease. The approach that is followed is one size fits all, but that probably is not the right approach, particularly as we are unrevealing more and more new mitochondrial genetic conditions, which might be amenable to specific dietary modifications. You've heard from Shanti about empirical supplements for mitochondrial cocktail. And there are different approaches, either going stepwise, introducing one supplement at a time, or giving few at a time, depending upon how severe the child is presented, and then taking off the ones which we think have not been useful. These supplements help in optimizing the function within the mitochondrial cell at various levels. Now, what is the need for a good diet? It is a balanced diet is useful and needed at all age, but particularly very important in children to ensure a healthy growth and development. You'll find that children who have iron deficiency, for example, are very irritable because of the need for iron for adequate cerebral functioning. Similarly, for children particularly, it's important to have an adequate nutrition to ensure a good cognitive development. It's also important to have overall improvement in the physical development and to optimize their potentials to the maximum. A lot of children with mitochondrial diseases have poor exercise tolerance, and we'll find that an adequate diet, managing their micronutrients and macronutrients adequately, will improve their overall well-being and improve exercise tolerance and help them to participate in therapies. Sometimes we find children have funding for a lot of therapies, but they're so exhausted, they're not able to make through the entire session of physiotherapy or occupational therapy. So it is important to have an optimal diet and well-being for a patient to adequately participate in his day-to-day activities. Now, how do we assess nutrition? There are various ways. Clinically, when we look at children, particularly most important in early life, is to look at their height and weight and measure the weight for their height. This is measured as a Z score. And also look at other markers of nutritional deficiencies, including upper arm circumference. We do skin folds, biceps, triceps, subscapular, and suprailiac skin folds to look at the skin fold thickness. And there are various other ways to measure resting metabolic rate as well as respiratory quotient. Indirect calorimeter is another measure of measuring the respiration at rest and during exercise. It's currently considered to be the gold standard. In mitochondrial diseases, diet is an important adjunct therapy. Like I mentioned, there is no clear consensus on the type of dietary modification that can be used. But from other diseases and other chronic illnesses, we do know that nutrition plays a very important role in many, many chronic illnesses, particularly important in pediatric population. Any illness can bring the nutritional status down and make the child prone for infections and further deterioration in their nutritional health. Various dietary modifications have been trialed, like ketogenic diet and modified Atkins diet. However, there's a lot of controversy about what can be used in which condition. And we have to be very careful when we use this particular diet because they are not suitable for all patients. The ketogenic diet may be useful for some group of patients, but not useful for others, and in fact may be potentially harmful with the higher fat content. Now, with macronutrients, when we say macronutrients, we mean in general, the food that we consume, which consists of glucose, lipids, and amino acids. So these produce energy, which is ATP, also produce acetyl-CoA and NADH, and lead to reactive oxidation species, which Shanti has mentioned are toxic to the cells. The eventual outcome of these is there is a need for higher CoQ10, and this eventually produces superoxide and hydrogen peroxide, which can cause oxidative damage to the cells. Reactive oxygen species also produce mitochondrial damage and produce a lot of changes in the signaling of the cells. So there's a lot of things that happen in the at the cellular level within patients and people, which varies with the diet that they consume. So amount of fat that you eat, amount of carbohydrates that you eat will change the concentration of NADH, reactive oxygen species, and alter the oxidative damage. So we have to be very careful about the ratio of carbohydrates, proteins, and fat that is given to individuals with mitochondrial diseases, because a slight increase in any one of these components can increase the oxidative damage and cause more harm than benefit. Proteins are important, and it's important not to restrict proteins because they provide amino acids for antioxidant enzymes. They also cause alteration in the mitochondrial DNA methylation and reduce the oxidative phosphorylation capacity if there is a restriction of proteins. So it's important that in order to maintain a good oxidative phosphorylation capacity, we have enough proteins and not restrict proteins. There are multiple micronutrients which have been used and which are important to be at an adequate level. So, for example, copper is important to maintain oxidative phosphorylation as well as cytochrome C oxidase enzyme activity. Zinc is very important for carbohydrate and protein metabolism, also useful for nucleic acid synthesis. It is a cofactor for antioxidant enzymes and prevents DNA breakdown. Zinc is actually very important, also useful for immunity, and it is something that we measure annually in our children with mitochondrial diseases, along with some of these other micronutrients. Manganese is also important in oxphos, selenium, and fat-soluble vitamins, vitamin A, E, and vitamin C. These are important. They are antioxidants and they protect damage from ROS. And folic acid, again, they are important for DNA synthesis and repair. A lot of B group vitamins, which are used in the mitochondrial cocktail, are useful for biogenesis. CoQ10, again, this is something that we generally use for most mitochondrial patients, preserves the inner mitochondrial membrane and is a scavenger of the ROS, and also useful in electron transport chain from complex 1 and 2 to transfer it to complex 3. So which is basically happening at a very a cellular level to produce energy. So we find that you find that empirically we will use CoQ10 and may change it later if we find that it's not beneficial. But most of our patients start up with being on CoQ10. A lot of other supplements are used. Some of them have specific role in certain diseases. So for example, we would tend to use carnitine and B5 pantothenate in a lot of patients to increase the CoQ10 pool. Certain cofactors as part of mitochondrial cocktail, some rate limiting substrates like arginine, folinic acid, creatinine, and enzyme activators, especially if there's a lot of acidosis, which is dichloroacetate, and vitamin C and E as an antioxidant measure. So currently, different strategies are used for different diseases. For example, arginine inhalers. One of the important things which has come up recently and is still very controversial is ketogenic diet. It has been useful, particularly we find it useful in patients with mitochondrial diseases with refractory epilepsy. We tend to use ketogenic diet and it seems to be beneficial. However, it's important to note that ketogenic diet is not for all mitochondrial mutations. In some patients, it has helped in some mitochondrial myopathies, but certain diseases have been exacerbated. It may not be well tolerated by all patients. High fat content can be mitotoxic, and therefore it has to be done very carefully under guidance with an expert mitochondrial dietitian, which we're very fortunate to have here in Perth Children's Hospital. Also monitor the long-term risk because of the associated fatty acid imbalance and increase triglycerides, which may happen in patients on ketogenic diet after using it for a prolonged period. The modified Atkins diet, again, which is similar to ketogenic diet, but slightly different. There have been some trials looking at modified Atkins diet, and again, quite similar to ketogenic diet, but not necessarily useful for all patients. It may be useful for some patients, but not necessarily for all. In modified Atkins diet, the predominant diet consumed is fat. Now, there are a few questions about diet in mitochondrial diseases which are not yet answered. For example, what is the load of carbohydrate intake? How does it affect the glycemic control in mitochondrial diseases? There are some supporting evidence, some concerns about glucose infusion. So again, it depends on an individual child, what their mitochondrial mutation is, and how they tolerate a carbohydrate load or a fat load. It also depends on what the child is doing.